work or remove it if they don't work. So the first issue that I always see as a barrier in this kind of a scheme is the traditional adverse selection. So the idea that a very highly cost individual may join and there is not enough resources, there is an explosion of cost and use of resources. So how can you reduce adverse selection in this pool of scheme based on community agreements and low payment? So that's a key issue. How do you solve adverse selection? And the typical issues are mandatory enrollment, but you have to do it at a group level. So working with association, with group, and trying to get big group, it's a fundamental issue to create a sustainable system in Nigeria. The second thing is maybe to consider enrolling household rather than individuals, and go for again with the group rather than the individual. The third issue is maybe bundle participation in these health savings rather than premiums with other microfinance or other trusted mechanisms that you have in the communities. So that may help enrollment. The point of the matter is to accelerate the pace of enrollment. So the person that is enrolling people in this community have a very fundamental work, which is accelerated so that you can pull more resources. So in terms of the behavioral economics, the classical issue is opting out as a default. So you may have a bundle of microfinance with health, but you have that enrollment automatic in the scheme. So that's very important. So what drives participation, it's not income or individual income or capacity to pay, but design. This is very important, the architecture of the design. I think framing this as a contribution, health saving, rather than a premium or contribution, it's more like an investment in your health. It's like a saving for the community and being healthy for the community, and the woman and the child. It's very important. So the framing has been very impactful in Ethiopia, in Peru. Kenya have very good experience with the default option. So that's, for me, it's very important to increase enrollment, highlight immediate benefit and salience. So when you market this cooperative, you have to have stories with immediate and salient benefit. The second issue here is, and I'm again using just the hat of an economist, it's to have sustainability in fiscal revenue. I don't think that when we teach people in public health, we tend to teach them how important it is to think about where you're going to get the resources and how sustainable are the funds. So usually when I travel around the world, what I see is that the taxes level to fund, or the funding, the sources of funding for this kind of insurance schemes are not very robust and sustainable over the long term. So you have to think about how you can commit revenues to this initiative. That's a really important issue. So earmarking revenues to this system, it's important. But now here, the fundamental issue is transparency. And I think Dr. Adejo raised a fundamental issue, which is trust. So transparency and trust are very highly connected. So transparency means having a dashboard showing how where the money comes from and where the money go, so that your community can trust. So transparency, you don't build trust in one day. It's trust is a social capital, so it takes time to develop, and you have to work on that step by step. And the important things about this capital that we tend to use it a lot, the word trust, is that if you lost trust, it's very difficult to gain. So you have to go step by step, building up that capital, with always in mind that a step in the wrong direction could be very costly. So you cannot have a strong system if you don't have a stronger source of revenue. Here, the next issue is out-of-pocket expenditure and key issues. So I will make sure to control out-of-pocket expenditure, that it's a source of inequities, it's a sort of not access to care. I will pay it. One thing that I see a lot in this, it's paying more attention to essential medicines. We usually pay attention to medical care services, but attention to medicine that are cheap and very effective, uh, uh, and make sure that you reduce out of pocket in those services and increase maybe out of pocket in things that do not have much externalities or spillover. So that's a very important issue. So we can discuss later about package of medicine, but that it's important to keep in mind. Again, framing this as a health saving, framing this as a membership, framing this as a community rather than a payment for your services, it's very important. Maybe using technology reminders so that people pay the membership as well as the out of pocket. It's important. The next two issues that I have, it's, you have an informal sector, a very prevalent informal sectors. How do you guarantee or encourage or nudge participation of low-income informal worker? It's very difficult. So maybe flexible payments and bundle, depend on your occupation, could be an interesting issue to explore. Digital micro payments could be also an interesting issue to basically, essentially, what you want is to remove the friction to enroll. Because you have, a lot of informal care worker, this could be an important issue to consider. So, and the fifth and last issue that I'm going to touch, and then I'm going to stay quiet, is the idea of governance and accountability. I mean, those systems, what I see in my 20 plus years of experiences, is that those systems appear, get stronger, and then get weaker. Then when I think about, I mean, we tend to think in a static way. A lot of energy at the beginning, the community is working, providing these services, some examples, but you don't have the governance that provide this a sustainable path during the time. And that is very, very important. So clear contract, clear sense of where the contributions are used, how we are benefiting the community, it's extremely, extremely important. I think we should work more on that. The visibility and the feedback, scorecards for provider. There is so many instruments that I can spend 1 or plus hour talking about it. But the message here is the idea of governance and accountability, and how can we make visibility a force to propel these kind of systems. So in conclusion, community financing can drive public health, not just medical care use. Community financing should focus on services that improve women and child health, that have externality over the community. This type of cooperative agreement could be economic and health impact. As I see health as an investment. As you have healthier community, you have more productive community, and that will come back. That cycle will be a positive cycle. So that's how as an economist, I tend to think about this. So let me stop here. I took one more minute than what I was allowed, but I think I open, and I will be happy to take questions later for expanding one of the policy or nudges that I suggest. Thank you so much.
All right, thank you so much, Prof. Yeah, thank you for also reminding us again, that, we, especially among the informal sector, we need to be more flexible, and we need to strengthen the governance and accountants framework. So thank you so much, Prof. I will be coming back to you with a few questions later. But now let me just go to Dr. Ijoma Ilo. She'll be speaking to us about, the ESUSU model. ESUSU is a local word for cooperatives in Nigeria. She is familiar with the Enugu model, of how they used, that cooperative model to fund care for women and children in Enugu. So, Dr. Ijoma, we invite you to speak to us for the next 10 minutes. Thank you.
Good afternoon. I'm going to talk about Isusu model in Enugu State. But meanwhile, let me start with first one. Let me start with the Isusu. Isusu, usually called Isusu in the conventional language in Nigeria, but in Enugu State, the name is Isusu. And this represents the Igbo traditional way of saving money for some events. Before now, the Ngwa people of Abia State, their young men usually save money for bride price, because those days bride price was high. So they save this money to be able to pay the bride price. But this has translated to saving to other large expenses, especially in recent time, healthcare. And in the Southeast Nigeria, in Enugu State, in Ojiriva local government area of Enugu State, they save towards maternal healthcare. The origin is of Isusu has become known in every part of Nigeria and some West Africa. It existed before the British colonialism, where people gather money and put this money under somebody who is trustworthy, because trust is a major issue when finance is involved. And this has spread to other parts. Recently, it has evolved from just informal banking to modern, informal contribution to modern banking. Still, both are coexisting now. How does this Isusu work in our locality? Women in the community, they come together either through church, through neighborhood, or through women organization. They come together and each member agrees to put up something small that is within reach, something that a person can always pass with at the moment, put it together, and this can be on a weekly basis, on a monthly basis. We have some also on a daily basis, but the most popular ones are weekly basis and monthly basis. This small amount of money is affordable. It is meaningful enough to build a collective pool that can be sourced for when somebody is in need. The pooling of funds. The contributions are deposited into a communal large sum where there is transparency, where there's accountability, and where they feel that their money is safe. Because this is done by people they know, people they interact with it, there is some high level of trust. Then the funds come into rotatory funds, whereby one person takes this month, the other person takes next month. They continue to do it until when the money has gone round to all the members, they may decide to continue or to end the Isusu. The Isusu has done a lot of things in reducing maternal mortality and morbidity rate in Enugu, especially in Ojiri Local Government, where I worked with women on this Isusu in 2018, 2022, and 2023. It makes funds available to them to use when they have need. And because they have these funds, Isusu, with them, they are able to seek healthcare. They're able to make decisions to move when it's needed as regards their health. They're able to fund it. And when they get to the health facility, they're able to be managed under skilled midwives. They are taught to prepare for birth and to also be ready for complications. It also enhances their social well-being. Because they support each other, it also increases satisfaction in this area. Isusu in Enugu State has been a practice for several decades, and then are making funds available for specific projects like childbirth, pregnancy, childbirth, and delivery. And in Enugu State, it has helped a number of women. During pregnancy, these women were encouraged to put some money aside that can be assessed for health purposes. Why this model prioritizes antenatal care, delivery, and postpartum care, some groups have extended it to cover needs like family planning, where a woman will save money because she doesn't want to get pregnant immediately after delivery. They are able to finance their family planning and even treat major or minor illnesses and also postnatal care. The flexibility of this institution has made it possible that the women are able to participate in it because they don't just save for just antenatal. They can also move it to other child care and other family needs. But most importantly, they relate it to child's care because to maternal care, because when a woman is pregnant, the woman becomes the community responsibility. We want safe delivery. We want safe pregnancy. We want safe postpartum care. What is the success story of Isusu in Enugu State? Improved access to maternal care. One of the clearest achievements is that more women are able to feed well. They have some money in their on grant. They're able to finance their feeding. They're able to pay for antenatal care. They're able to pay for their routine drugs to do antenatal care, and they're able to even save money to buy delivery requirements. It also has improved their financial protection of family. They don't need to worry about how to raise money to go to hospital because they have saved earlier for this. The money is on ground for them to make use of. Cultural familiarities with Isusu. Isusu is not new. It's deeply rooted cultural practice among Igbo and Nigerian society. Women were already accustomed to pulling forms for weddings, burials, and other social engagement. So moving this thing and adapting it to health financing makes it easier for women to trust and participate. Trust and social capital. These groups are usually built around existing social network, people they know. So contributing money, keeping it to people they know is easier than keeping it for people that they don't know. The collective responsibility. The society sees that pregnancy and child delivery as a community or social work that will enhance the community well-being and development. So the women are interested in making contribution to their own well-being. It also ensures their flexibility. They are not rigid. This amount is put aside the much you can afford to do, the more you can part with. There's no rigid amount that you must pay, and there's no interest. Even when you delay a little bit in bringing the money, they're not subtracting. So they're comfortable with it. And they do this thing and put this money in the hands of who they selected among their group. So the trust is high and is managed by themselves. And because it's managed by themselves, it's their own, they take ownership. They want it to succeed. They want the community to benefit. They want the women and children. But in the society, the vulnerable group are the women, the pregnant women and children. It strengthens social solidarities. This scheme reinforces community bonds. Women not only save together, but support each other together, emotionally and socially, creating a sense of shared responsibility for health and well-being. It also has this flexibility and responsiveness. Unlike rigid insurance model, community finance adapt to local realities. Funds can be used not only for antenatal care and childhood, but for other urgent family health needs that they need to attend to. Women empowerment. Managing contribution and funds builds women financial literacy. It helps leadership. It boosts their confidence. Knowing that they are able to contribute to their own health care gives them that confidence. Community visibility. When women see that others are benefiting from this, they want to benefit. In Nigeria local government area, we started this research on Isusu with about 15 women. By the time we come in, we are back in 2022, there are about 50 women because they have seen what it has done to the community, and we term this community visibility or benefits. What are the challenges of Isusu? Isusu had 3 challenges. We have the operational and management challenges, we have the systemic and financial challenges, and we have the external and economic challenges. Under operational challenges, we'll have the problem of keeping record with pen and paper, which could get lost, which there could be errors, and we have mismanagement and fraud. Because this money are kept in people's hands, the high tendency that there could be fraud, there could be mismanagement is high. The lack of formal documentation. This makes it difficult to hold individuals accountable and track contribution correctly. There are other systemic events. We have lack of formal regulation, we have low financial literacy, we have limited flexibility, and because no interest or returns are made, Isusu savings do not earn interest, meaning that the value can be eroded by inflation, as we see every day in Nigeria. External and economic challenges. We have economic hardship, we have lack of formal integration. All these things are making Isusu are kind of challenges to Isusu. But despite that, Isusu has survived in Enugu State, Nigeria, especially in the Nigeria local government area of Enugu State. How do we scale and integrate Isusu into formal banking system? Isusu model can be integrated into formal National Health Insurance Authority by adapting it to collect and pool health insurance premiums for informal sector, which is a major challenge in Nigeria national universal health coverage. This can be achieved through partnership with microfinance institutions that already use Isusu system to facilitate regular small-scale savings from individuals in the formal sector. These savings could be collected and transferred to National Health Insurance Authority as health insurance contribution, making formal health insurance more accessible and sustainable for those with fluctuating and daily income, like the local women in the local government area, who their income are usually every 4 market days. But in the Southeast, we have market, there are local market days comes every 4 days. And we have the Eke, Oye, Afo, the River is usually every Eke. So they contribute, instead of weekly as a normal weekly, 7 days a week, we have just 4 days a week in their weeks are counted by 4 days. So they make this contribution every 4 days towards their maternal health needs. We also have co-financing arrangements that can help to make this integration possible. We have flexible financial benefits. We have transparent partnership with health facilities, capacity building and oversight, gradual integration, but not replacement. To prevent mismanagement as funds grows, training in record keeping, training the women in record keeping, financial literacy, and governance should be provided, while still letting the women themselves run the scheme. So oversight should now be supportive, not top down. Because when the seas are being top down, they may have resistance and they may lose trust. But when it is gradual and supportive, the transition will be seamless and they will be comfortable with the transition. There should also be gradual, because when it's not done gradually, they may resist to it. But when it's done gradual, the risk of eroding trust by imposing external control, integration should be gradual, allowing groups to retain autonomy while progressively linking them to a broader financial protections. What are the steps that can be taken for integration? Partner with financial institutions, collaborating with microfinance banks and other financial institutions that currently use or can adapt to this Isusu model will be of great value. Then developing digital platform, leveraging existing mobile and digital platform to create seamless process for collecting contribution and managing them. When this is seamless, the women will be carried along and they will be comfortable with, and they will support the process. Establishing collection and pooling mechanism, implementing a system to collect the pooled Isusu contribution from the financial partners and channel them to National Health Insurance Authority for health insurance funds. Create tailored insurance products, design affordable specific health insurance plans that are suitable for international sector workers with premium that are aligned with the regular income streams. What are the benefits of this health integration? Benefit of this integration of Isusu to formal method will improve access. To increase access to formal healthcare by making it more affordable and convenient for informal sector workers to pay for their insurance. And in the developed government area of Enugu State, we see that women there, they are more of informal workers. They are traders. They deal with palm produce, making their income well reduced compared to their contemporaries outside the Enugu State or other developed part of Nigeria. Financial inclusion. Promote financial inclusion by providing structured way for informal workers to save and pay for healthcare. Sustainable funding. This will create a more suitable and predictable funding stream for healthcare, reducing reliance on out-of-pocket payment, which is a big problem in Nigeria. Some people are denied healthcare because they're not able to afford healthcare. But with this Isusu and possible integration, they will be able to afford their own healthcare that will make will improve maternal outcomes, make maternal outcomes and also neonatal or infant outcomes too, because women are linked with neonates and children. Enhanced pooling broadens the insurance pooling by bringing more people into the financial system, which can lead to better risk sharing and improved overall health outcomes. So in essence, the lesson is that trust and flexibility come from community ownership. So if government and national health insurance authorities respect that foundation and position themselves as partners rather than controllers, Isusu type model can scale without losing what makes them successful. And what I think that made them successful, trust, paying according to what they earn, and making it also tailored towards their health needs, maternal health needs. So in recommendation, I feel that government and donors should establish national matching funds that directly support women community-based savings. This action could help. Matching funds means where every naira a woman saves, government or partners add proportionate amounts, which will instantly strengthen these community pools without undermining ownership. This approach respects the grassroots trust and solidarity already in place established by Isusu, while giving the groups greater financial muscle to cover high-cost services like cesarean section and other postpartum complications and emergencies. It will also be an initiative, an incentive to participants, because women who see that their savings are doubled or multiplied will want to save and want to contribute. Over time, this creates a bridge between informal Isusu scheme and formal insurance system, ensuring sustainability and wide coverage. So in summary, investing directly in what the women are already doing for themselves by scaling up contribution savings towards matching mechanism, government, donors, and cooperatives can make affordable, accessible healthcare a reality for women in Enugu State and Nigeria, where Isusu is already established as helping them to finance their healthcare needs. Thank you.
All right. Thank you so much, Dr. Ijoma. You have said so many things. You know, we have been able to understand how the Isusu model in Enugu works, and you have given us some actionable recommendations as well. You know, just like you said, one of the most interesting things I heard from what you said is that we should make it a bottom-top approach, not a top-bottom approach. That's so the top can just perform oversight functions, and that strengthens, you know, and builds trust. I know, especially making one of the women participate, a major stakeholder in managing those funds. So thank you so much for your insights. And so I'll quickly go to Mr. Abakuri from Ghana. So he can share his insights on how the experience from Ghana have been able to ensure that cooperatives have been integrated into their own formal insurance networks. So Mr. Abukari, so we'll hear from you now, sir. We have 10 minutes, sir. Mr. Ahmed, can you hear us? Okay, I don't think he can. He's muted. Okay, so that we'll come back to you, sir. Let's go to Mr. Atama. Mr. Atama, sir, you have heard so much about what Prof. and Dr. Ijoma said. You know, Prof has shared his own insights. Dr. Joma has shared what happens in Enugu. You are the head of the Cooperative Financing Agency of Nigeria. Can you share your experience? You know, because you know one of the earlier panelists talked about regulation. You know, you sit at the top of that regulatory body, sir. And from your own experience, how can we ensure that we leverage existing cooperatives wherever they are in Nigeria to support health insurance access? Sir, can you speak to us, sir?
Thank you very much. Cooperative greetings to all of us on board this discussion. I'm very delighted to be here. At the National Cooperative Financing Agency of Nigeria, which is the apex body for all financial cooperatives in Nigeria, we've worked closely with the central bank and other regulatory authorities in what we call the National Financial Inclusion Strategy. My humble self happened to have chaired the product working group for financial inclusion in Nigeria for 2 terms. And I have a very rich experience with regards to the subject matter. During my period on board the financial inclusion strategy, healthcare happened to be one of the cardinal objectives. We have 5 items: savings, credit, insurance, capital market products, and pension. And the cooperatives play a greater role in ensuring that people are included. So under the insurance product, we have the health insurance. Then coming home to the cooperative, we set up what we call the cooperative inclusive strategy. And what we were saying is that cooperative is not all about savings and loans, but all other products that make one strong. We're also looking at it from the perspective of what is obtainable within the workspace. Like the formal workspace, like government and organized private sector, they have access to healthcare through the National Health Insurance Authority. They have access to pension, they have access to housing, and all of these are contributory. Then you discover that the informal sector person cannot boast of this because they don't have a vehicle through which they can channel this contributory scheme. So the cooperative became a veritable tool to entrench this, in the sense that in the cooperative, you have what we call peer pressure. So if Mr. Tama can do this, that means Mr. Ola can do this. And we did not segregate. We look at it from the individual and the group perspective, in the sense that if you are yet to be married, you are covered as a person. But if you are married, the entirety of your family is covered. So we did not segregate between women and men. And we are also saying that in cooperative, we don't have men, we don't have women, but we have members. So long as you are a member of cooperative, you are entitled to all these benefits as contained in the cooperative inclusive strategy. And what are they about? Finance, healthcare, pension, housing, renewable energy, access to education finance, and then access to agriculture inputs and market. But we have this conclusion within ourselves that health is wealth. Without health, you cannot do all this. So when we started it in 2017, we look at the cooperative governance structure, because under the law of cooperative in Nigeria, that is the Cooperative Societies Act 2004 Cap 98, laws of the Federal Republic of Nigeria, the cooperative that we know is grassroots. It exists at the world level and can operate in any part of the state that it is registered. So from the point of registration, you discover that the cooperative is grassroots. And if it is grassroots, and all the cooperatives in the various parts of the country are connected in this health endeavor, then we will, through that, entrench what we call universal health coverage. So when I was the chairperson of the product working group, we're working closely with the National Health Insurance Authority, and even up to now, to make sure that we achieve the universal health coverage. And how do we intend to do that? Those that are in government and organized private sector do their contribution through their offices. Members of the cooperative do their contribution through their cooperative. Why we are very confident of this is that it is not just healthcare that we started doing this contribution through. We have achieved some level of success in housing with the Federal Mortgage Bank of Nigeria. And that is why today, if you go to the Federal Mortgage Bank of Nigeria, because of the cooperative contribution, more loans are given to cooperative for housing. Talk about pension. It was under my watch as the working group chairperson, working together with PENCOM, that we'll be able to achieve the informal sector pension scheme, which a lot of people are contributing today. So we have looked at two critical areas we have achieved success. Healthcare also is very, very important. So the cooperative will now be the focal point of contribution. When the members bring in their savings, a portion of the saving is meant for healthcare. But before that, how we've been operating is with HMOs. We have operational working agreements with them. We have packages of various categories, and the cooperative member who brings himself, his wife, and the children in, select any of the package comfortable to them, and then they can make contributions towards it. And this contribution could either come from them directly, immediately, or come as a loan facility from their cooperative to the HMO to give them the opportunity so that when they are sick, they will have opportunity to go for medical attention. So for us, since 2017, when we brought up the cooperative inclusive strategy, we've been working very strong with government and development partners to make sure that we achieve the universal health coverage. So that is our modus operandi. But in terms of regulation, the governance of cooperative, the cooperatives have what we call autonomy and independence. That autonomy and independence, as contained in their registration certificate and bylaw, enable them to run their own affair without any undue interference. Then, in terms of the regulation, it could be federal, it could be state. National cooperatives are regulated by the Federal Department of Cooperative. Then the state cooperatives are regulated by the State Department of Cooperatives. And when we talk about regulation, what are we talking about? Their registration, their supervision, their control to ensure that they comply with global best practice is what we refer to as regulation. Then the governance is in the hands of the cooperative itself. And as parent body to this cooperative, the National Cooperative Financing Agency from time to time hold regular conferences, hold regular meetings to ensure that the people are well educated with respect to how to run their cooperative. In fact, we have developed a technological framework like the Unified Cooperative Platform that will be celebrating 10 years next year, February, that keep records of the cooperative accounts and administrative setup. And somebody will ask question, what about these village women? What about these village people? How can they be part of it? You see, the law we have is that when you go to the village setting, you will see that the teachers are there. You see that the nurses are there. The community health workers are there. They also are members of these cooperatives. So when it comes to helping the cooperative put their things together, this category of persons are the ones that help them. So the argument of saying these local people, how can they embrace technology? It is not true that everybody is local in the village. In fact, in one recent discussion, I told somebody that in my village, we have what we call University of Health Sciences in my village. So in my village now, can you say everybody is completely illiterate? Because the vice chancellor is there. The working group are there. So they are not completely illiterate, because when you go to the village, you will see local government workers. They are educated. So what we say is that they are change managers. They, as part of those cooperatives, help us to make sure that the village people also imbibe modern way of doing things. Then apart from that, we looked at the frequency, sustainability of these contributions to make sure that you don't have a break in the healthcare provision. We now deployed another technology called Aquila, which is helping us in direct debits. Because in financial inclusion, of which health insurance is an aspect of it, you have to be enrolled financially by giving you a bank account. It could be a tier 1, tier 2, or tier 3 bank account. But the fact remains that through the direct debit, their accounts are tokenized. And on a regular basis, their cooperative contributions come into the bank account to enable them make their contribution through their cooperatives. So for us, the technology we have deployed is helping us to make sure that contributions come as at when due. And then to say that we are not just jumping at this issue. We have made calculated effort through our partnership with the central bank under the financial inclusion strategy. And we have also domesticated it in what we call the cooperative inclusive strategy, of which healthcare is a cardinal point and objective to achieve. So we are saying that this type of program is good to create broad-based enlightenment. When I look at the chat room and I see people coming in from different parts of the country, I say, wow, that means we are actually heading towards the universal health coverage. So for me, it's a welcome development. And I believe that cooperative with its peer pressure, cooperative with its governance and formal setting that moves you from the informal to the formal will help largely to make sure that whatever goal we want to achieve health-wise will be achieved, particularly as we have it on board our strategy to ensure that no one is left behind. Thank you very much.
Thank you so much, Mr. Atama. It's exciting to hear that under the cooperative governance strategy, healthcare is one of your cardinal points, and that you have also advocated that this should be used, to fund access for women. So that's a very interesting insight. I don't know if we have Mr. Bukhari here right now. I don't think I saw him a couple of minutes ago, but let's go to Dr. Jade Solaidu. You are the Chief Operating Officer of one of the largest HMOs in Nigeria, and you have heard everybody speak. You have heard how trust is an issue. I also heard Mr. Atama also douse some of that tension to say everybody is educated, even at the local levels, that we can actually deploy technology to harness these cooperatives at local level. And we have seen from the social model as well that those things exist at our local levels. So how can HMOs, as one of the partners in ensuring that these things come to fruition, how possible is it from your angle? What are your experiences and what insights do you want to share with us today? So we'll listen to you, Ma, for the next few minutes. Thank you so much.
All right, thank you, Dr. Aderibigbe, and good afternoon, everyone. All right, so at Mansard, we are not just dealing with the formal sector. We're actually also dealing with the informal sector and also partnering with the NHIA with what we call inclusive insurance to get healthcare, not just to the people in the corporate world, but to every other person in Nigeria, even in the informal sector, with our microinsurance products. But now talking about cooperatives, we must know that cooperatives are actually very powerful entry points, and they are built on trust, that has been said by Dr. Ijoma earlier, accountability and shared saving structures. So we have these cooperatives even in our offices, everywhere. People are coming together to do a susu and making contributions. And it's not just financially, even the farmers, you know, in the rural areas, people are doing all sorts of cooperatives. So there's already some trust in cooperatives. And then they also organize goals around credit. So where they contribute and then somebody collects the money at the end of how many months, and then it goes round and they continue like that. They also organize around food supply and other business support. Now, health can easily become the next shared goal if we can access these cooperatives and get them to buy into it. Because healthcare, we know, is wealth. Health is wealth. And if somebody is not healthy, then you can't even do any business. You can't even be available to help your family. So health can easily be harnessed through these cooperatives, and which is also our goal, to penetrate these cooperatives and see how we can get more inclusive insurance across to the populace. Now, at AXA Mansard, we've seen how private HMOs can partner with these cooperatives and co-create simple, affordable, and relevant health packages, especially for women. I mean, you told us at the beginning, women have a better health-seeking behavior, not just in Nigeria, all over the world. And maybe more importantly, because they are the ones having children, they are the ones going for antenatal care and also going for immunization for the children. And the men are doing the macho, and they would not even go when they even have health insurance, except they start breaking now. So with that value in women, hopefully we can actually create products that will be attractive to them and also will be affordable, which is what we do in AXA Mansard. Now, this coverage actually includes coverage for preventive care, preventive health. We're big on wellness and talking about health education, healthcare, giving health talks, free health talks to market women in different places, and cooperative groups. So preventive care, very, very important to us. Maternal health, is so key. Talk about antenatal care, prenatal care, and postnatal care. Infections, and even mental health and wellness, which is key in these days of a lot of stressors all around us. Now, the focus for us in AXA Mansard is not just on hospitalization, but on keeping our women healthy. I told you we're big on wellness. Wellness Revolution was our target at our 10th year anniversary 2 years ago, where we talked about Wellvolution and the need for all of us, not just to be treating diseases like malaria, but to be preventing it. And we are key and very big on that. Now, the focus is not just on hospitalization, but also on keeping women healthy and productive every day. How have we been doing this? Our approach has been community-based for our inclusive insurance. Like, you know, we are a national HMO, with over 2,000 hospitals all over the country that are our partners, and all the diagnostic centers and other radiological services. We also partner with them and laboratory services. Now, but in those rural communities, in those interlands, in Karanamoda and Bomosho and other places where, you know, this way too, that people are not getting to, we also have partnerships with pharmacies, and we have products. Like the one I'll talk about is our AXA Pass product, which is available through our agents. So how have we been doing it? We've been using a lot of mobile agents. We have a lot of professional state staff all across Nigeria. We're talking of over 10,000 all across the states, where they go to sell this AXA Pass. AXA Pass is just 1,000 naira, which is even less than $1. How much is $1 now? Now, with 1,000 naira per month, somebody can have access to basic primary care, which is what most people will suffer. And our data shows this. Malaria is still the #1 diagnosis all across Nigeria, then upper respiratory tract and other things. So we have designed a product that covers basic primary care that forms 70% of what people present at the hospitals for. Now, we have partnership with pharmacies. With this AXA Pass, they buy it for 1,000, they use a scratch card, and they're able to have a USSD code, even on their mobile phone. They're able to get access to the nearest pharmacy and make a call where telemedicine services are available. And with this, they are also able to have medication where they'll be sent to their nearest local government to collect the medication from the pharmacy. So the AXA Pass products, 1,000 per month. So if somebody buys it now and they end up having any infection or anything, any illness, they make the call and they are able to access care. Now, we also have partnership with telcos. We have the Airtel product also that has been on for a while, where if you subscribe to Airtel, which is one of the telecommunication companies in Nigeria, you're able to access care. This is all basic primary care, because not everybody is going to ask for cancer care or the other big ones, but basic primary care, including maternal care, is covered in this. And just to mention that when the pharmacists cannot handle it anymore, we have a partnership with our hospitals all across Nigeria where they can refer. So we are not just leaving them in limbo that, oh, it's no longer primary care, sorry, we can't do it. We actually send them to any of our providers all across Nigeria to continue the care once it's beyond primary care or something beyond what the pharmacy can handle. So our mobile agents, professional sales staff are into this. We also have an approach where we do community-based enrollment, which is where the cooperatives come in, where we have different groups that come to us to register, whether as SMEs or as different businesses, apart from the corporates that form 70% of our clientele. So where we go directly to the women where they meet, just like this Esusu, we have a lot of market women groups. I mean, we started sometime with Lagos State trying to do some partnership with them. We're still in touch with them. And even with the NURTW, all these very organized setups where we know that they need healthcare and they also need a lot of health education, especially on alcohol intake and all sorts of practices that are not healthy. So we're in touch with them, and digital sign-up is what we are next on, especially with fintechs. And we've actually signed an agreement, and we're working right now with PalmPay, which is one of the fintechs, and that is able to, I mean, they're all over Nigeria too. So with their partnership, we are able to also sign up people through what we call digital sign-ups. And with these options, we also have what we call pay small, which is like the Esusu thing, options, where they're able to pay installmentally, which is what makes it very inclusive and accessible. So unlike the corporate plan where they have to pay upfront and pay maybe biannually, and this time around, we're talking of flexible payment to cover basic primary care, and we give them those options through the partnership with the fintechs like PalmPay, where we have partnership. We're also planning to sign up with other telcos and like Glo and even other fintechs. But PalmPay is on board now, and we're enjoying the population, because we're talking of over millions now that have been enrolled through them. And that has been helpful to a lot of people that otherwise would not have had access to healthcare. Now, we combine this with health education sessions where we build understanding and trust before enrollment. This is very important to us, because why treat malaria if you can prevent it? So what do? For all our cooperatives, for all our groups, including the corporate clients, we have regular health talks, and we go to them. These days for the corporates, we do a lot of virtual talks. But for the market women and the other informal sector people, we actually go there, even do some kind of community outreaches and check their blood pressure, check their blood sugar, and now educate them on the need for environmental sanitation to prevent malaria, on the need for good nutrition, and not just giving their children Indomie and all the noodles without fruits and vegetables, without protein. So we do a lot of that, and they appreciate it. And even through that, we're able to enroll more people through those community outreaches. So through those visitations and health education, it has brought a lot. Our AXA Pass has actually been able to penetrate, and we have over how many? About greater than 5 million people enrolled all across Nigeria right now through the AXA Pass products. Now, our plan is to scale this model. I mean, you gave us the statistics at the beginning, which is really not the best. I mean, Nigeria's health indicators are not okay. 998 per 100,000 live births of maternal mortality, even though it's an improvement from the other 1,000. That's still not acceptable in a country of 208 million people, and that is trying to become one of the global partners in the world in the year 2030 with the Vision 2030 of the government. So we must address it. Our women are still dying, not just in Karen and Moda and the remote parts of Katsina, but even in Lagos, where we have a lot of traditional birth attendants that are not trained, and then they are taking deliveries, and then with a lot of sepsis, women are dying. So how can we address this? Our plan is to scale up this model, where luckily Lagos State is doing some partnership. We also have partnership with their state health insurance, along with NHI, where we can train these TBAs, because they are in the communities and they are not going anywhere. So can we train them? Can we get them to do proper referral we talk about the 3 levels of delays in access to maternal care that leads to this maternal mortality. Can we reduce those delays and empower women? Those are things we're already planning. So the scale up is actually our goal, even in AXA Mansard. Now, to scale up this model, we need structured partnerships, which is where the cooperatives come in, and which is where we're grateful for this opportunity to NSSF. To scale up partnerships, we must have structured partnership with cooperatives, and these cooperative bodies must also collaborate with us. We also need interoperable enrollment systems. What this means is that we have a big CBA, core business application, that we use, that's, all our hospitals are able to access care. But the men and women in those remote areas that we want to give inclusive insurance may not be able to access it. So we need some form of interoperable enrollment system that can include them even at their level, which is where the telcos come in, and the PAMPay and the other fintechs, where with their own digital structure already established, and when these people enroll and open accounts with them, they are able to reach out to them, and with our partnership with pharmacists, access care, basic primary care. So these interoperable enrollment systems will enable us penetrate more and get more of our population enrolled, especially in the informal sector. We also need blended financial models and financing models that keep premiums low while ensuring quality care. This is where we also need the fintechs. People may not be able to pay. We have a lot of people living less than $1 per day in Nigeria. We're talking of over 200 million people. Or is it 120 million? So basically, they cannot pay the full upfront of even the regular plan of our corporate plan. So what do? We can do what we call premium financing. And then they are paying, like in installments, like they do in the Isusu model. So basically, we need this partnership with the cooperatives so that when people are registered, we are assured that their payments will be made. And if they also register with the fintechs, we're sure that even if they just pay an entry point, we will give them access to care, hoping that in the next quarter, something else will be paid, and over 3 quarters, we will get the full payment. This is how we can have inclusive insurance, which is what we hope to scale up, even with our cooperatives in Nigeria. Now, because in the end, and the truth of the matter, which all of us should be interested in, and the government has started this by making healthcare mandatory, health insurance mandatory for all Nigerians. That was in the year 2 years ago, 22. And the NHIA Act that's made it mandatory must also support it beyond the letters. Now, this is the time for implementation. We are open to collaboration, even with the NHIA. That's our plan. Now, it's important that this inclusive innovation is never only about technology, which is also very important to us. Yes, we have the technology platform, but the rural areas that form 70% of our population are not able to even have access to internet, talk less of having those digital things. But we are able to have mobile health, remote care, and other platforms in partnership with a lot of innovators that are even in Nigeria. Now, we have a lot of telemedicine platforms. We have a lot of mobile health platforms that we partner with, GeroCare, and many of them that are all over Nigeria that are able to access these rural communities. Now, innovation is not just about technology, but we are hoping that we'll be able to design products with empathy and also deliver care that truly fits the women's realities. What are the women's realities? Basic things they need. They get pregnant, they need antenatal care, focused antenatal care, they need prenatal care, they need postnatal care, they need immunization for their children, they need basic primary care even when they fall ill. And of course, they need financing, because one of the things, even from research that we have seen, is that because a lot of women are not empowered, one of the levels of delay is that sometimes they wait for their husbands to even give them the minimum basic things. Meanwhile, if they had a petty shop or some form of financing for themselves or some form of empowerment, then they can be able to take care of their own health needs and go to the hospital when they need it. Take their children with high fever to the hospital without waiting for the man that may not come till night. So empowering the women is also key. And this is not going to only be by the HMO. We need the government to set up a lot of empowerment scheme, getting women in basic petty trading and all sorts of financing and empowerment so that they can be empowered financially. Now, we also have an opportunity with the National Health Insurance Authority, NHIA, our regulator, and the state insurance scheme like LASHMA and even Ogun State and many other states, that's Delta and all over Nigeria, that are setting up state health insurance schemes. Now, this insurance schemes can act as gateways for women enrollment, because now they are the authority in the states, and the plan is that with their support, we can have access to enrollment for women and have affordable and quality healthcare for them. Luckily, we are a national HMO with hospitals, over 2,000 hospitals all across Nigeria. And in any part of Nigeria, we have facilities there. But beyond even hospitals, we have partnership with pharmacies, partnerships with diagnostic centers. So regardless of what the care may be, there's somebody there that is linked with AXA that can offer healthcare. So we hope we can partner with NHIA and with other state insurance schemes towards getting our women quality healthcare, because they will form the gateway into getting more women enrolled for affordable and quality healthcare. Our plan also, which is what we have actually started doing with our microinsurance product like the AXA Pass, is to design women-centered benefit packages that can address community needs, that include the prenatal care, family planning, very important. We're having women, especially in the North, young girls with VVF. Right now, we have a partnership with the NHIA for obstetric care. We call it the CMOC project, where there's funding to take care of women with VVF, vesical vaginal fistula. And these are young girls that have been married early to old men that have given them VVF and they are leaking urine because they were not even matured enough to have children. So right now the government is taking over their care, because in the past they were just abandoned by these men and then they took another wife. Right now we are part of the partnership where we're sending them to specialist centers that do those repairs across the North and even some parts of Southwest in Edo and other parts. So we're in partnership with them also for obstetric emergency care, which are the drivers of this maternal mortality rate that is still not acceptable at 993 per 100,000 live births. So NHIA has come to the rescue, thanks to Dr. Kelechi Oheri and the team. So we are one of the drivers with the NHIA in driving this product, but this is focused on maternal care and obstetric emergencies and VVF. But we hope we can expand that, which is the next stage, beyond the obstetric emergencies that we are already doing with NHIA, beyond the VVF repair. Can we get partnership with other state governments and design products targeting women, basic antenatal care, postnatal care, infertility, and family planning, so that the women will have only children they need? Because sometimes, because of lack of access to family planning, they're just having children and the children end up with malnutrition. They don't even have money to take care of them, to feed them. So we are open to partnership with more state governments. We're actually in discussion with many of them. And we have these vehicles already. I mean, we have a robust platform, but the plan is that for the scale up, we hope we can have integrating digital payment systems, more with the fintechs, more with the telcos, and contributions that can be automated, because now collecting things manually may not be that efficient, and then things may be mixed up. I mean, I see these two people carrying paper and collecting, but we're talking of 220 million people that are unreached. So how can we get them? We need some automation. That is where efficiency comes in. And I mean, fintechs are already doing it. And of course, transparent, trackable platforms that are open and these women can access. And this also platform should be able to allow these women save in micro installments, which is where the SISU come in, so that today, after they've sold something, they can give 100 naira, tomorrow 200, where they can save in micro installments through their cooperatives while enjoying continuous coverage. So they're not going to pay the full premium, but even with a premium down payment of a minimal amount, with the promise and trust of the cooperative, we're able to give them access to care, and they are able to pay over time throughout the course of the year. Now, even in AXA, just to mention, we already have what we call a premium financing program, even for our retail plan. And the retail plan are the individuals that are not in the corporates, in the formal sector, that want to access care. So a family of 4, they come, and then other retail products. So a premium financing where, through some guarantee with some banks and an investment platform, once they register there and we are sure that they already have a savings with them, we're able to give them healthcare after they make the initial payment, and over time, at least in a maximum of 4 installments, some is 2 or 3, they are able to pay because we have a guarantee with the bank. So that's already ongoing, and we call it premium financing. And that is also what we want to bring to the cooperatives who are already well structured with trust, that with our premium financing, you can have access. These women will be able to have access to healthcare even without paying the whole premium at once. Now, this is where the fintechs also come in. I said we also already have a partnership with PalmPay and even telcos like Airtel. Private HMOs like AXA Mansard also can partner with these cooperatives and co-create wellness program. This is also important. Different sectors of Nigeria have different needs. Like I said, in the north, where they focus on VVF because of early marriages. But in the southwest, the focus is actually on a lot of young girls having unplanned pregnancies. So the focus per region will be different, which is where we need the cooperatives to be able to reach out to them. I mean, in AXA, we do a lot of CSR. We just had a community outreach to our community. Sometime back, we were in Ikota, and you see a young girl of 20 with 5 children, and all of them looking like they are twins because you can't even say who is older. Now, so the Southwest has its own needs. They are not having VVF here. And that means if we can form cooperatives with all these communities across the nation, we can target their own needs after doing a proper situation analysis and give them a product that addresses their needs. And also we have partnerships with other innovators that also are partnering with AXA Mansard, like for cancer screening, which is the number one, breast cancer is the number one killer of cancer in women. We have this Oncopadi innovator that also does a lot of wellness and education. So breast cancer screening, maternal health education, those will be things, and wellness program will be planning. And we hope we can plan with the cooperatives. I'm glad the head of the cooperatives are here. Now, this approach that we are deploying in AXA Mansard actually blends financing, technology, and trust. And those three are key to deliver quality healthcare. So once you have appropriate financing that is accessible and affordable to them with digital platform and the technology and the trust, then this will ensure that both women in formal and informal sectors have access to quality healthcare without any financial hardship. Now, the goal, in summary, for us in AXA Mansard is clear. And our proposition to this committee is that we want to use cooperatives as vehicle of inclusive insurance, which is what we are already doing, linking communities, digital system, and social protection framework to scale women's healthcare and wellness sustainably across Nigeria. Thank you.
Thank you so much, Dr. Jadesola for AXA Mansard. It's impressive that we have seen that you have partnership already with telcos, fintechs, and you're already leveraging technology to improve access for women. It's okay. Professor Antonio, before we started, I'm sure that you have another engagement. Would you like to make some additions, sir? Please, if you have questions, please can you just drop them in the chat box and we can take them. Mr. Bukawi, we're coming back to you. Prof, over to you, sir.
Thank you. Thank you. So yeah, unfortunately, this has been a very interesting conversation, but I need to leave at 9:30. But I wanted to say two things that I want the audience to keep in mind. So the first thing is, if you think about cooperative, this is an area where you need network effect. You need more people to, like people enrolling in Facebook or enroll. So think about an entity that need to have network gains. Otherwise, it's not sustainable. So every context have different ways to propagate the good words and the incentives to enroll. But it's key that you think carefully about what are my 3 or 4 actions, concrete actions, to gain the maximum of network effect and measure that. You need to, it's like a fire. You need to propagate that. If you don't have that at a certain speed, and you can calculate the speed of the system, so to speaking, meaning how many people do I need a month in this fire to keep it going. As you get more people, more services can be provided. So the second issue is at the early stage of this cooperative, not everything can be offered. So trade-off needs to be done carefully. So if you ask me and you hire me as a consultant, I will put a lot of emphasis on services that have what we call spillover or externalities. And I will put a lot of attention to medicines that are crucial to take care of patients with chronic conditions, medicine that are crucial to take care of children, vaccines, and things like that. And then as I get these sources of benefit of enrollment, then I will expand. The next issue that is crucial in these systems, it's transparency. You really need to have a scoreboard. You really need to have transparency. Otherwise, people will not enroll, people will not trust. And the last, to conclude, it's a very important issue. All the panelists mentioned something that I love, which is health. It's an asset. We need to improve health to have a virtuous cycle of getting richer, right? Getting more growth as an economy and getting more people participating in the economy and growing. So we all mentioned trust, and it's a good word, right? The market don't function if we don't have trust. A lot of things don't matter. But how do we measure trust? How do we measure that people are trusting us? How do we get the word around that we are trusted? I think you really need to move from the trust issue to the issue of how can we materialize or how can we really monitor to what extent people are trusting, because otherwise we are talking about something that morally it's correct and that we need it, but we don't have any measure and any objective way to provide a North Star for us to move forward and strengthen this system. So in that, I congratulate all your initiative. I hope that we keep growing. It's very important that we pull resources through cooperative, but we need to think carefully about how can we sustain this system over time. So with that, I will excuse myself. I really enjoyed. Pleased to meet in every person in the panel, and I'm a professor at Hopkins. If you need me, just one email away. It's amazing that we can do this through Zoom, talking about the benefit of technology. I really enjoy it and learn a lot from all of you. Thank you so much.
Thank you so much, Prof. Thank you so much, Prof. It's a pleasure to have you. We know you need to leave.
Yeah.
On behalf of NSSF, we thank you for joining this exciting conversation. And we'll be in your email, definitely. We'll curate the questions and we'll get it across to you so that we can get back to the feedback back to those that really want those answers. So thank you so much, Prof, for attending. Yeah. So, Mr. Abukari, can you hear me, sir? Can we hear briefly in the next 5 minutes from you on how you have been able to integrate, cooperatives into your financial markets in Ghana?
Okay, thank you very much. I wish to apologize for the mishap that occurred when it was my time to present. As I mentioned, I wish to apologize for the mishap that happened during my time of presentation. In Ghana, the history dates back to the 70s when we had issues with what we call the cash and carry and full cost recovery. In the 70s, there was the introduction of what we call user fees, facility user fees for health facilities or hospitals, if you like it. And then later into the 80s, we have what we call full cost recovery. And by full cost recovery, it means that people were now to pay for all services that was rendered at the facility. And this is a journey that Ghana has traveled. And that is a journey from what we call the community-based system into the general or the national health insurance. In Ghana, what happened was that once the full cost recovery was introduced, in the 80s, then people shy away from the hospital. So hospitals like the hospital in Koranza, which is the St. Rita's Hospital in Koranza, reported low attendance. By that, people now decided to stay home and either treat themselves or use other means. People will say they will go for herbal medicine and home. So the result was that you had higher death rates or mortality. And so people will report to the hospitals late, and then there was nothing or virtually nothing that the facilities could do. So they end up dying on arrival. So you notice, or what we say is that in Ghana, the Koranza scheme, thought to be the pioneer scheme in 1992, initiated by the St. Teresa facility or hospital in Koranza, with the support of the Catholic Church, of course, for the Catholic facility. And they offered what we call the prepayment for healthcare to reduce out-of-pocket payments or expenses. Then later, in 3 years' time, in 1995, we had the introduction of the similar system, this time supported by GIZ, a German-based NGO, and that was in the West Gondia district. Here again, there was a system that was built around the community trust and solidarity. Okay, and further into 2000, there was another similar community-based system established in Lodowa near Accra, the Dangme West community-based health insurance. And all of this is to support individuals within the system who make prior contributions before falling ill. And so anytime any of these members come to the facility, provided you have joined the scheme, then the scheme would pay for all the services that you pay, or all the costs that you will pay whilst you are in the facility. Then in trying to nationalize this particular unit or pilots, then the state came in 2003 to form what we call the establishment of the Act 650, which was an act that tried to nationalize the activity or the pilot that has been done across as far as community health insurance is concerned. And it was initially district-based with local governance. So each system or each district had its own district mutual health insurance scheme. And then that system had even board or members who regulated their activity. They were able to accredit facilities on their own. They are able to receive claims, vet claims, and pay verified claims to facilities. They were also given the opportunity to be able to invest funds or idle funds so that they could accrue interest and make the funds useful and not idle. Then we moved from that system to a nationalized system in 2012 when we introduced the Act called Act 852, the year 2012. And this time around, instead of making it district-based, most of the things were centralized at the national capital with an authority to regulate the activities of all of these. So there was a strengthened governance and accountability mechanism. There was a nationalized claim vetting system. And there was this recognition of what we call the corporate or private health insurance system, which is broken down into private commercial and private mutual. In that system, the private commercial means that they are very economic based, and for that matter, profit oriented. Then the private mutual system, that is still close to the community-based system. It's also there to meet the mutual needs. So members are in it and are contributing for the welfare of themselves and their families. So in the mutual system, you will notice that in Ghana, the Act outlined people who fall or can formulate the mutual from a health insurance system. So it could be a community coming together, it could be a group of women, it could be a group of men, and all of that. So the experience we have in Ghana is that you have regulated a particular group of members who were just Muslim women in Medina, okay, came together to formulate what we call the Takapo health insurance. And their motive was just to contribute resources, and then as and when any of the members fall ill, they can rely on the fund. So the system, as we have it now, is a system that has matured to a particular level, building on the basis that we had the early 90s up to today. Now the benefits or the achievement has been that there has been increased access to health. Because like I mentioned earlier on, since the introduction of the cash and carry system, people shy away from the facility. People could no longer pay, so they had to withdraw. And withdrawal also meant that people would fall ill, they would get to the exchange before they rush to the hospital. Then the facility would have less, these people end up dying. So it's the introduction of the health insurance system from the mutual level or from the police basis international system. They are able to increase access to healthcare, able to reduce financial burden, okay, on citizens. And greatly that I have mentioned that we are able to reduce material impact. Currently, as we speak now, about 55% of population in Ghana are people who are registered in the national insurance scheme. The national insurance scheme. This is not including even those who are within the private insurance. These are people who are within the national insurance scheme. So the system, as we have it now, has also centered what about public-private partnership with healthcare delivery. Because the private facilities, there are private facilities who are partnering with government or the national insurance scheme to be able to deliver healthcare, and they are also reinvest as and when they are being used. So all in all, I would say that it's a community-based system has helped us develop a nationalized health insurance system. And as we have it now, the communities are still allowed, or groups are still allowed, even within the law. There's a space for people within a company, from a mutual health insurance scheme, people within the church system, they to form a mutual health insurance scheme, or people within a work situation. Even within the company, you can have a department within the company coming together to form health insurance or mutual insurance, do contribution, register, one.
All right, thank you, Mr. Bukari. Thank you for sharing the Ghana transition from the 90s, to exactly where you are today, and how the benefits of how that has helped, in providing access to healthcare. So we'll take just 2 or 3 questions from our audience. Please, if anybody has a question, can you raise your hand so that we can unmute you and take a question? It will take not more than 3 because time is fast spent. And Esther, please, can you help us moderate the questions so that people can ask? We also have a few in the comment box, which I'll read out shortly. But if we have anybody that wants to ask a question, can we take that?
Okay, we have Ahmed Usman, whose hand is raised. Please unmute yourself. You've been given permission to speak. Please ask your questions.
Good afternoon. Can you hear me?
Yes, we can hear you.
Hello, good afternoon.
We can hear you. Please go ahead.
I'm Ahmed Usman from National Health Insurance Authority, precisely Gombe State Coordinator. First of all, I want to congratulate you for organizing this Zoom meeting, where we were given the opportunity to listen to all these wonderful presenters and educative discussions. Here in Gombe, the NHIA has a CBHI program, which why I bring this is because there's one speaker that was saying asking for if a woman can contribute 1 naira, that other donors, the government should come in and complement with the same amount. I want to tell you, at the moment now, the CBHL program in the state is being financially running through the NHIA, and at the moment, the cooperative in that community, the NHIA is taking care of all the pregnant women and children under 5 in that community, free. And the state office is only there to look at the flow of funds and to see what they are doing. Through that, the community, as we speak now, have their own primary health care. And they also kind of apply to NYSC every year. Doctors were posted to that facility. They were being accommodated. Pregnant women were being treated free, and also children under 5. Someone made mention of the NHIA Act that made health insurance mandatory. I want to tell us that it is not only the responsibility, it is not the responsibility of NHIA only to make this become possible. It is a collective responsibility. What I'm doing here in the state is that the first thing I did when I came in, I tried to look for local partners because I realized sensitization is paramount if we want to achieve anything. As we speak now, my local partners used to sponsor the state office or pay for airtime, local radio stations, television stations, where we go now with the introduction of the CMO program and the NHIA free program, we have done quite well. And also, I want to say something on the part of the HMO. One of them, Aksa Mansa, was speaking. HMOs also has a duty. They has a responsibility to sensitize the teeming population. They have responsibility to go down to villages. And when they come to a state, I advise, sometimes they bypass the state office, they just go to those communities. The state office is on ground, we know the terrain, we know the people, we know where the vulnerable people are. We have so many things that we tools to recognize who is a vulnerable person. So thank you very much. Once again, I congratulate you all. Thank you.
Thank you so much, Mr. Ahmed Usman, who is the Gombe State Coordinator of the NHIA. We thank you so much for that insight. Yes, you have said a lot. And I'm happy that you took points of what each speaker said, and you are able to, lay some clarifications for us where necessary. Thank you so much, sir, for that comment. Is there anybody else that has a question before we go to the chat box? Okay, so let's quickly just go to the chat box and see. Take a few questions. Okay, there's a question for Aksa Mansa there. I don't know who this is from, because the person said you have a first referral from my hospital in my local government. Sorry, this person did not put a local government, so I'm sure that Dr. Idowu may not be able to understand which local government you are referring to. Okay, so there's a question that just dropped now, and it's for Mr. Tama.
Araba Donga local government. Just put it now.
Okay. Okay. I don't know. Do you want to answer that question, Ma?
Yes, so let me just answer. Of course, we are open to it, but we will partner with through your state health insurance, because the state health insurance, and I'm assuming that we have one in Taraba. Can you confirm that you have? So what I can do, I'll drop my email address and we'll take it up from there, because we have to work with the state HMOs just the same way we work with Lashma in Lagos. So the HMO, if there's no state HMO, then we can take it up as a private health insurance. So I'll drop my email address and then we can take it up from there. But what we'll also be advocating, because it's not just enough for your local government, is that the state should have a state health insurance program for the whole state and not just your own Donga local government. But it starts from a local government. And of course, I hope there'll be ownership by your local government chairman and the senatorial people too in that district, being able to take ownership and make it accessible to all the people, not just in your own local government. So we're open to it and we will be glad to partner with you. Thank you.
All right, thank you so much for that question. The next question is to Mr. Tama. I think somebody asked earlier that at CFAN, do you have a pool of cooperatives, that, HMOs can leverage on in terms of maybe HMOs want to work with cooperatives, how do they partner with CFAN to ensure that they leverage? Because one of the most important things you said, sir, during your presentation was that there's no compulsion in this thing, right? You just encourage, cooperatives to take up health insurance plan. So how can that partnership, especially when HMOs want to partner with, CFAN and reaching out to these cooperatives, to build that trust, as with CFAN being like a mediator, to ensure that, oh, you have been working with us, we trust these people, you can get this done with us.
Thank you very much. What happened is that we enter into an MOU, a working agreement with the HMO, because on our own board, we also have experts that cut across healthcare and health insurance, so that we vet what should be done, and then it becomes a template for all affiliate cooperatives under us to benefit. That is what we have been doing, not that the cooperatives go and do it on their own. We have a structured arrangement with a time frame, renewable, such that once the cooperatives say we are interested, we now connect them to the HMO, and it operates on the basis of what we have put in place between us and the HMO. Thank you.
Oh, okay, great. So it's good to know that Stefan has a template, already established template where, the cooperatives can leverage on, and then they can work together with willing HMOs that, that can partner with our cooperatives especially. And we encourage HMOs, definitely, and everybody that is listening as well. So, the cooperative network already exists. The leadership of CFAN is already exploring that option. I want to challenge and encourage everyone to take up that option. There's so much we can do with collaboration and partnerships to ensure that we can upscale this model. Dr. Ojoma has already shared her experience with the social model, how it has worked, and the benefits and the success stories that we have seen from that model. So please, again, it's good conversation. This conversation does not end here. We'll continue to scale up this conversation. And if you have other questions, please, you can just drop them in the chat box. We'll harvest it and share with our panelists so that they can get responses across to all of us, because our time is fast spent at this webinar. So once again, let me thank every single person who started with us and who has attended this fireside chat. Let me hand over to Mrs. Deborah Abodunri, who is the head of operations of the Nigerian Solidarity Support Fund, to give us a vote of thanks. Mrs. Deborah.
Okay, good afternoon, everyone. On behalf of the NSSF, Nigeria Solidarity Fund. Sorry, can everyone hear me?
Yes, we can hear you. Please go ahead.
Okay, thank you. On behalf of the NSSF, I want to say a big thank you to all our participants and our distinguished panelists for joining today's fireside chat themed From Savings to Solutions, Community Models Driving Women's Healthcare Access. To all our incredible speakers, Professor Antonio, who is not here at the moment, to say thank you, Dr. Ijoma, Mr. Ahmed, Mr. Emmanuel, and Dr. Jadesola Ido. We say a big thank you to you for sharing such valuable insight with us and the practical lessons from your diverse experiences. Your contributions have really and truly deepened our understanding of how cooperative and community-led financing can transform women's healthcare access across the nation. And I want to say a special Appreciation to our MD as well, Dr. Fejuro, for our inspiring leadership and continued commitment to fostering conversations such as this that connect innovation, equity, and sustainable healthcare solutions. And to every participant who joined us today, we say a big thank you to you for your time, for your engagement, and for your thoughtful reflections, your active participation. To make this section impactful, we say a big thank you to you. And as we round up and close, we say I want to admonish us to carry forward the key things that we have heard here from today's conversation, that collective action, community financing, and inclusive partnership, they are all powerful tools for achieving equitable healthcare for women in Nigeria and beyond. Thank you all once again for being part of today's dialogue. We look forward to seeing you in our next session. Until then, we say thank you and stay fired up.
All right, thank you, Dr. Mrs. Deborah, for that. Also, again, on behalf of the board and management of Nigeria Solidarity Support Fund, we thank everybody, especially our esteemed panelists. We'll be curating this conversation. We'll share some, the synopsis of that with everybody on the team. And then we hope that we can make further comments so that we can translate these conversations into policy and then put it at the desk of every single stakeholder that matters in this country. Thank you very much once again, and it's bye for now. Thank you very much.
Thank you.